Hello my friends, my name is Dr. Saeed Kazmi. You're watching me on my YouTube channel Pediatric Talks with Dr. Kazmi. Now in today's lecture, we are going to talk about interpretation of serum creatinine, blood urea nitrogen, and serum abscess as well as urinary electrolyte in the context of renal function tests. So in other words, in this particular lecture, we are going to talk about interpretation of some of the renal function tests. Now, earlier I had made a video that is the interpretation of renal function test part 1. If you haven't watched that video, I would advise that you go back on my channel, search for that video, watch it, then come back and then watch this video. So without further ado, let's dive in and get started. So the first thing is serum creatinine. Now, serum creatinine is done as a part of the renal function test. Now, what is creatinine? Now, creatinine basically is a metabolite which is formed from a protein known as creatine. This creatine is present in the human muscle mass. Now, as you are doing your activities daily, this protein is broken down. And this creatinine, when it's broken down, it is ultimately converted into a compound which is known as creatinine. Now, this creatinine is constantly filtered by the kidneys. And one thing is very special about creatinine is that, it does not depend, it does not vary by the sort of a time of the day. There is a constant excretion of creatinine in the urine. So that's why creatinine is used as a standard when we are trying to see if the renal functions are changed or not. We can compare it, for example, with urinary proteins. We can also compare it with the blood urea nitrogen, which I'll explain in a moment. But as I said, that creatinine is basically a metabolite which comes from the muscle protein called creatinine, and it is filtered by the kidney. Now, approximately every day, around 2% of your muscle mass in the form of creatinine is converted to creatinine and then eventually filtered out from the kidneys. Now, how much of the creatinine goes out of your body? It depends. It depends on your age. It depends on your gender, whether you're male or female. More in males because they've got more muscle mass. And it also depends on your body size, how big you are. Now, in adults, the normal range of serum creatinine, that is the creatinine in your blood, measures I would say it varies around 0.6 to 1.2 milligram per deciliter, while in females it is 0.5 to 1.1. So there is slight variation. Females have got slightly lower normal serum creatinine levels as compared to males. Again, the reason being that males have got more muscle mass. Now, as I told you, because this is filtered constantly in the urine, in case if your kidneys are not functioning properly, what would happen? You would not be able to filter creatinine. So what would happen? The levels of creatinine would rise up in the blood. So creatinine is taken as a very sensitive marker of your renal function. So if the serum creatinine is more than 1.1 milligram per deciliter in males, and one or some books say 1.2, some say 1. Anyhow, let's, for the sake of simplicity, we take it as 1.2 in males according to my lecture, and 1.1 in females. So if it is more than that, it means the serum creatinine is increased, and it simply means that there is some compromise of the renal function. Moving on to another parameter which is checked as a part of the renal function is your blood urea nitrogen. Now, blood urea nitrogen, sometimes people confuse it what is this blood urea? Simply, when you do your renal function test, you might have seen blood urea. Now, this blood urea is basically blood urea nitrogen, so they are used synonymously. So many labs would simply use the word serum urea, while some would use blood urea nitrogen. So they are the same thing. Now, what does it measure? Now, blood urea nitrogen actually measures the metabolism of proteins. This urea basically is formed in the liver as a metabolism of proteins. So whatever proteins you have been taking, you've been eating, or your body has been metabolizing, ultimately the end product is urea, and that is formed by liver. So liver forms urea, and that urea is then filtered in the kidneys. Formed by liver, filtered by the kidneys. So normal levels of urea in the blood, because it's being formed constantly by the liver and constantly excreted by the kidneys, the normal level ranges between 7 and 20 milligram per deciliter. So between 7 and 20. If it is less than 7, it means your blood urea is low. That can sometimes happen if somebody is suffering from malnutrition or is taking less proteins, or in some vegans as well. Who knows? And if it is raised, we are more concerned if the serum urea level is raised. So if it is more than 20 milligram per deciliter, it means that the blood urea nitrogen or urea levels in your body have gone up. Now, if it has gone up, it simply means that number one, either the kidneys are not functioning properly, and if they're not functioning properly, obviously this urea would not be filtered properly and the urea levels would go up. But at the same time, there are certain other conditions which can also sort of cause a rise in blood urea nitrogen or serum urea, and that is the hydration status. So if somebody is suffering from dehydration because of any reason, for example, they've not been drinking enough, or for example, they've been vomiting a lot, or they've got gastroenteritis, like any form of fluid losses, then the serum urea levels would increase. It's simply because the fluid level has gone, out of the body, so the concentration of urea has risen. So remember, blood urea nitrogen and urea is not only an indicator of your renal function, but it's also an indicator of your hydration status. So the question is, if somebody has got, let's say, an increase in blood urea nitrogen or serum urea, how do you know if it is caused by let's say dehydration, or is it caused by renal function? Though sometimes dehydration might lead to compromise of the renal function as well. But anyhow, for that we use a ratio, that is the blood urea nitrogen to creatinine ratio, or BUN to creatinine ratio. So let me explain that. Now, blood urea nitrogen to creatinine ratio is simply your blood urea levels as and you compare it with your creatinine levels. So normally, let's say if your renal function is compromised because there is some problem in the kidney damage due to any reason, so what would happen? The creatinine would also rise, because the creatinine would not be able to be filtered by the kidneys, and at the same time urea will also rise. So both would rise proportionately. Creatinine also goes up and blood urea nitrogen also goes up. So the ratio does not suffer, though both have gone up. Like for example, the urea goes from 20, let's say, to 40, and let's say the creatinine goes from 1.2 to 2.4. But see, both have increased, but the ratio does not change. But if, let's say, the creatinine remains normal and the urea goes up, so what happens? The ratio has gone up because urea is more increased as compared to the creatinine. That would mean that there is problem with the hydration status. So the BUN to creatinine ratio actually helps you to distinguish between causes of acute kidney injury, whether it's being caused by dehydration or whether it's being caused by, like, let's say, intrinsic renal damage. So a high ratio, for example, let's say the normal ratio is usually 10 to like 20, or some books say even 8 to 20. Usually the average is around like between 14 and 50. So if it is more than 20 to 1, then it means that the BUN to creatinine ratio is increased, and the BUN to creatinine ratio is increased in conditions like dehydration, because there is a fluid that's gone out of the body, and what is happening now is that there is less blood flow to the kidney. But if both are increased but the ratio is the same, then it means that there has been an intrinsic renal damage. For example, it can occur in acute glomerulonephritis. It can occur in any condition in which the kidneys have been damaged. So that was blood urea nitrogen to creatinine ratio, or BUN to creatinine ratio. Moving onwards, let's talk about electrolytes and how electrolytes are related with your kidney functions, or how do they help us in knowing the renal status. Now, there are two types of electrolytes that we do. One are the serum electrolytes that are mostly done, like, as part of your part of your renal function test. Serum electrolyte, that includes your serum sodium and serum potassium, sometimes serum chloride as well. But at the same time, sometimes we might have to do urinary electrolytes. And by urinary electrolytes, we mean we have to check the levels of the same sodium, potassium, and chloride in the kidneys. Now, normally, again, most of the times we are mostly interested in urinary sodium because most of the problems associated with, let's say, kidneys in general can be diagnosed if we have got and like if we assess the urinary sodium. Though in certain cases, urinary potassium and urinary chloride can also be done. For example, if you are thinking of renal tubular acidosis, Bartter syndromes, things like that, then maybe you have to do urinary potassium and urinary chloride as well. But by and large, when we say urinary electrolyte, we mostly do urinary sodium levels. So the normal sodium levels, are around like 140 milliequivalent. The potassium is 3.5 to 5. Some books say 5.5 milliequivalent per unit. And again, they are mostly regulated by our intake and how our kidneys are functioning, and at the same time, the acid-base balance as well. Now, the normal levels of these electrolytes are very important to maintain a sort of a normal homeostatic environment in the body. Now, imbalances can occur. For example, if the renal, let's say there has been some damage to the kidneys because of any reason, because let's say it is because of obstructive uropathy, or it is because of, let's say, pyelonephritis or glomerulonephritis. So if there is an acute kidney injury, whether it's in the form of acute or maybe it goes on to cause a chronic kidney injury or chronic renal failure, what happens? Most of the times we see that either the serum sodium is low and the serum potassium goes up. So serum potassium is a very good indicator. If it is increased in the body, you should definitely think of renal failure, because renal failure is one thing that can send your potassium levels up, because potassium excretion only solely depends on the kidneys. And in certain cases where the kidney is too much damaged, then what would happen is that the potassium levels would increase in the blood, and we call it hyperkalemia. And hyperkalemia is in turn very dangerous because it can cause arrhythmias and child can die because of arrhythmias. So hyperkalemia and hyponatremia. So usually low sodium and high potassium are associated with kidney diseases. Sometimes the opposite can also occur, but by and large, for the sake of simplicity, remember that most of the times it would lead to hyperkalemia and hyponatremia. Now, at the same time, because serum electrolytes can be affected by a large number of conditions, it's also important that if you think that there is sort of a diagnostic dilemma, you do urinary electrolytes. Now, urinary electrolytes, especially urinary sodium. And urinary sodium can also give you a lot of information, especially if you are confronted with a diagnostic dilemma in which the electrolytes are deranged and you don't know whether it's a renal problem in general or the problem is somewhere else. So how do we sort of interpret those things? So we do urinary sodium levels. Now, urinary sodium levels are usually interpreted if they are more than 20 milliequivalent per liter, or like less than that or more than that. So range of that, again, it has to be interpreted with your serum electrolytes, with your serum osmolality, and obviously so many other things, okay, which would be based on what conditions you are suspecting. So you calculate the urinary sodium levels, and at the same time you assess the clinical condition. So in clinical condition, again, related to hydration status are two things. Either someone is dehydrated or someone is edematous. Edematous means he's overhydrated. He has got a lot of fluid in his body. So if somebody is dehydrated and their urinary sodium level is low, that means less than 20 milliequivalent, you are basically dealing with a fluid loss status, like that. For example, it could be dehydration because of severe vomiting, viral gastritis, or viral gastroenteritis. But if a dehydrated person has got high urinary sodium, you say, okay, he's dehydrated, but his urinary sodium is high, you are probably dealing with certain conditions, like either the person has been using diuretics, either there's a history, you can find on his prescriptions that he's been using diuretics, or there might be diuretic abuse as well. Or diuretic abuse, if you're thinking of diuretic abuse, sometimes think about these adolescents with eating disorder as well. They sometimes use laxative abuse, and diuretics abuse can also happen in these guys. So be careful about that. Anyhow, so if a dehydrated person looks like dehydrated, sunken skin, but the urinary sodium levels are high, think of diuretic use, or sometimes it could be Addison's disease as well, where you would find low blood pressure, low sodium, high potassium, and there's high urinary sodium. What if the person is edematous? You feel like they've got edema. Then edema, again, if the urinary sodium level is low, less than 20 milliequivalents per liter, then you are dealing with congestive states. And these congestive states could be because of congestive heart failure, it could be because of nephrotic syndrome, it could be because of chronic liver failure or cirrhotic states. Whatever state is causing an edema in the body, either because of heart, liver, or kidney reasons. Again, the list would be quite big one. What has caused congestive heart failure? What has caused congestive uh, or let's say chronic liver failure? What has got causing nephrotic syndrome? Whatever is the reason, there is a congestion or congestive state of the body. And what happens is that they usually would be having low serum sodium as well, and they've got low urinary sodium as well. So think of the congestive states. But with the congestion, if they've got high urinary sodium, the serum sodium is more than 20, let's say going up to the 40 range, then you are thinking of renal failure. So in renal failure, what would happen is that they would be having high urine because again the tubules have been damaged. Whatever sodium is being filtered is not reabsorbed, and it's all going out in the urine. So these are a few cases. I mean, the list is not exhaustive, but there are a few cases in which you can think of certain, in other words, you can narrow down your differentials based on urinary sodium levels. But again, as I told you, urinary sodium levels have to be interpreted in the context of the clinical status. So whether the child is dehydrated or whether the child is edematous. So based on that, and based also on the serum electrolytes, you can make a diagnosis. Moving on to what else in renal function tests. So one thing is urine osmolality. So urine osmolality can be very simply calculated from urinary specific gravity. Now you'll be saying, what's this? Yes, it can be calculated from urinary specific gravity. There is a simple trick for that. So, when you are doing a urine dip or urine analysis, on that strip, on the top, you will be seeing that there is the mention of urinary specific gravity, like anything like 1.005, 1.0010, 1.010, 1.015, so on and so forth. So these values are basically the specific gravity, like how much concentrated the urine is. Now what you have to do is you take the last two digits of this specific gravity. Like for example, if the specific gravity is 1.005, the last two digits would be 0.5. If the specific gravity is 1.010, the last two digits would be 10, 10. And if let's say the specific gravity is 1.030, the last two digits would be what? 30. Now what you do, you take these last two digits and you multiply it by 30. So for example, in case of 1.005, the last two digits are 0.5 multiplied by 30, you get 150. In case of 1.010, the last two digits are 10, you multiply it by 30, you get 300. In case of let's say 1.030, the last two digits are 30, you multiply it by 30, and what you get is 900. So whatever you get is the urine osmolality, and the unit is milliosmoles per kilogram of water. Now you say, what is the normal range? Well, normal range, well, it's quite broad. It's like somewhere between 50 to 1200. Look at the variation, and it depends on the clinical status of the patient, how much the patient has been drinking water, whether he's been suffering from any, like to say, conditions like vomiting and diarrhea, whether he's edematous, blah blah blah. So urine osmolality in a normal person can vary a lot, like from 50 to 1200 milliosmoles per kilogram. But there's one thing that can help you. Anybody whose urine osmolality is greater than 700 milliosmoles per kilogram, one thing is excluded. So if they are passing a lot of urine, so at least they don't have diabetes insipidus. So a value greater than 700 milliosmoles per liter, what? It helps you exclude diabetes insipidus. It can't be diabetes insipidus. Like again, there could be a lot of differentials for high urine osmolality, low urine osmolality. So in diabetes insipidus, there are tests which are done, and if urine osmolality greater than 700, that excludes diabetes insipidus. because in diabetes insipidus, remember the osmolality never goes above 700. The urine is always very, very diluted. So this was all about some of the renal function test which we left over from the first part of the interpretation of the renal function test. I hope today you have understood the importance of serum creatinine. You have understood the importance of blood urea nitrogen and the ratio of blood urea nitrogen to creatinine, and you also learned how to calculate urine osmolality from what? Specific gravity. And we also touched about urinary sodium levels and how do we interpret urine sodium levels. If you have liked this video, give me a thumbs up and please do share it with your friends so they also learn how to interpret renal function tests. And if you haven't subscribed to my channel, please do subscribe and have a very good day. I'm signing off. Bye bye.